and we'll talk about that. You can have a transplant, which is possible for many people, not possible for others for various medical reasons, or you can die. Those are your three choices, because kidneys really are absolutely essential. And if they truly fail, you don't have very long. Hemodialysis patients in America, minimum that they most need. Of course, it should be really very specific to individuals. It should be tailored to individual biology, individual physiology. As Ryan McDevitt said, the big two tend to use a one-size-fits-all model. But the absolute minimum you can do to thrive on dialysis is 3 times a week, 3 hours a day. And it's better to have more frequent treatments and longer treatments. Location is key. You need a clinic near your home, unless you're doing home dialysis, which in the United States is not very well developed. It's actually quite a low number. 8% of hemodialysis patients are on home dialysis, as opposed to 50% in New Zealand, for instance. So that's sort of a backdrop to how dialysis functions.
And along those lines, Tom, like how often should a self-funded plan, if I'm a sponsor or somebody who works for a self-funded plan, how often am I going to see somebody who has the need for dialysis? I mean, these are big numbers, 560,000 Americans, but if I'm a plan, what should I be thinking about?
Yeah, it does vary a lot from population to population, but I think a ballpark figure is about 1 dialysis patient in every 2,500 adult lives per year.
Got it. Great. Thank you for that. And Ryan, would you mind, as an economist, kind of walking us through a little bit of the dynamics of the market from your perspective? Again, we have some stats on the slide, but would really like to get your kind of bird's eye economist view of how the market works or doesn't work in the big picture.
Well, absolutely. So if you start with the size of the possible pie for this industry, be the number of patients with kidney failure, now we have to talk about how do we serve those patients. And in the United States, we've made some specific choices along the way that makes us a unique deliverer of dialysis. So Medicare back in the 70s decided to cover all patients in the United States regardless of age. A rare opportunity to think about universal coverage in the United States, because we don't do that. Most parts of the world do, but the United States has developed a different system over the years. Dialysis is going to be special in a lot of ways, and that's one of the key things. Medicare is covering about 80% of patients on dialysis in the United States. So start with that. But then through another legislative quirk, we've also decided that for the first 30 months of dialysis, your private payer, if you have one when you go on dialysis, is going to pick up the tab. So although everyone's guaranteed Medicare coverage at some point, for those first 30 months, your private payer self-funded plan is still on the hook for that cost. And because we have 2 large dominant chains, those costs for private payers are 8 to 10 times Medicare rates at a minimum. That's what we're finding in the data. This is research we published 2 years ago. This is a markup that's extraordinary compared to all other healthcare sectors. I haven't seen one as large as dialysis. A typical markup, as we see in the slide, maybe 1.5 to 2 times Medicare. And this is a direct result of the concentration we see in dialysis. So 50, 60 years ago, a lot of dialysis was delivered by a local nephrologist. They had a clinic, maybe a handful of stations, a lot of hands-on care serving the community. There's a lot of money at stake here. Someone like Warren Buffett is very intrigued by the profit potential of dialysis. They can treat this like a fast food operation, to put it a little bit glibly there. This is the fast food of healthcare. So to make a lot of money, it's going to be a volume business for DaVita, Fresenius, the other big chains. The only way to keep improving earnings per share each quarter is to get more patients through your system and to increase rates for private payers. Those are the 2 ways to do it. You can drive down costs a little bit through bulk buying, getting some discounts on drugs, discounts on supplies, but the primary way increasing price of private payers and getting more patients through the system. 2 key ways. And as these big chains have gobbled up independent facilities one by one over the past 50 years, we're now at a point where DaVita, Fresenius own about 80% of facilities nationwide. They're earning an outsized share of profits. And most Americans don't have a choice. we're in the initial stages of research. We're finding that 1 in 3 Americans has access to only DaVita or Fresenius in their area. There is no choice for you if you want someone outside those 2 big chains. And that's a big issue for patients because we think of choice as being a primary feature of our market-based system. We want competition to deliver better results, lower costs for patients. We don't have that in dialysis. We're failing as a system in delivering competition and choice for patients. And unfortunately, we see a lot of cases where DaVita Fresenius, they find a patient's not profitable for them, they're being difficult, their care is too costly. They find ways to kick them out. They call it involuntarily discharging a patient. If you're in one of those areas, like 1 in 3 Americans are, where there's no other option in that area, you're out of luck. You might have to drive 50 miles to go to another facility. Or we're seeing heartbreaking anecdotes where someone says, that's too big a hit to my quality of life. I'm just going to stop dialysis. I'm going to die peacefully at home. And these are grim choices we're making most Americans face. And frankly, we thought that we have a moral imperative to have dialysis universally covered in the United States. And now we've gotten away from that. We want to bring that back now to the fore, that moral imperative to give this to every American who needs it. So sorry, a long, non-linear introduction here, but those are the main features of this really messy industry.
Go ahead, Tom.
I think that's no. I think it's highly linear because you've created the sort of perfect storm where we started off with a medical miracle, the first human organ to be replaced by a machine. People who had a kidney failure before were dead. I mean, in a matter of days, and suddenly you have this medical miracle, and it becomes a medical nightmare. And in my research, this market concentration, my book is filled with stories of involuntary discharge. And subsequent blackballing of patients who raise questions about the quality of their care or simply are unprofitable. That is my impression as a journalist looking at the data and interviewing hundreds of people in the industry. Horrendous work environments also for workers. I mean, patients are suffering, but also workers are almost subjected to MASH style military hospital units in a war. I mean, the level of understaffing, the level of pressure to get people on and off the machines is extremely high. Nephrologists are also suffering. They don't have the opportunity to practice medicine on a patient-by-patient basis the way they would want. I've spoken with many nephrologists say I lost control of my patients when I sold or when my unit was taken over. And then taxpayers. I mean, the mortality in America is vastly higher than any other developed nation, and it costs vastly more to treat them. So we're getting a bad deal. I mean, even from just a cold-eyed financial perspective, we're getting poor quality for service. I mean, our dollars are not being well spent at this point.
So let me ask a couple of follow-on questions. So one, actually, it came from Carolyn, who just put it in the Q&A. But Ryan, for you, so what, or maybe both of you, but why not antitrust kind of regulation from the government? So Ryan, maybe you can start, and Tom, I know you've done some work on this as well. But can you guys talk a little bit about the regulatory side over this, and then I want to come back to something that's much more specific to self-funded plans in a second.
No, that's the question of the day, and it's a very timely one because just yesterday I was at the Federal Trade Commission showing some results on dialysis. So it very much is something that's being looked into at the Federal Trade Commission. They're aware of this extreme concentration. The nerdy explanation from an economist, we have thresholds in the United States where any merger below, say, $100 million, the thresholds vary depending on certain things, but any merger below that is not going to be scrutinized by antitrust authorities. And how the chains have grown over the years, they bought up independent facilities one by one. These are at $4 million, $5 million, maybe $10 million transactions, but they're way below the threshold that's going to get any kind of antitrust look. So that, through that loophole, that's how we've gotten this extreme concentration.
And there's a wonderful paper by University of Chicago economist Thomas Woolman, and the title says it all, How to Get Away with Merger. And it's about the dialysis industry in America and how this roll-up took place.
Yeah, and so, there's a question which is I wanted to come back to, which is also in a concentrated market, can you talk, maybe Ryan, this is a question for you, but when a network exists for most medical services, we've got a robust market for those services. Can you talk a little bit about the fact that when we're in consolidated market, what does that do? What's the form of a network? You know, we put it here. Everyone automatically assumes, right, that out of network means that you're going to pay a lot more. But can you talk about kind of how the perversion of the market might change that in the dialysis universe?
Right. So, a few things as an economist we're going to look for here in a model of competition. One, as I mentioned already, the foundation of our system should be that competition is going to deliver better results. We're going to get higher quality, lower prices, lower costs. Everyone's going to win from that system. That's why we have this market-based system in the United States in the first place. But what we've seen, a departure from that over the past 50 years, a lot of consolidation, not just dialysis, but throughout the whole system, payers included, hospital systems included. Everyone now is more concentrated than they were 50 years ago. What that means is everyone's fighting over that same slice of pie. Every $1 of spending is someone else's dollar of income in a healthcare setting. And so the way to make more money is to have a better negotiating position. That's Econ 101 in this type of model. And who's going to have the better negotiating position? Whoever controls that scarce resource. And what you find in dialysis, this is an essential life-saving treatment. You have to cover this as an insurance plan. Right? And if you have to cover it for your patients, you have to pick up the first 30 months by law. You need to find someone for your patients to go. You have basically two choices across the country, more or less. Right? And for 1 in 3 patients in America, one of two choices, which means the Vita Fresenius have you captured, right? They have extreme monopoly power, unlike we've seen in any other sector of healthcare. Again, regionally, you might have pockets where there's more concentration. There might be a hospital system that dominates a local area, but nationwide, 80%, just 2 chains. I've never seen anything like it. And so, like you said, they're going to negotiate the best rates for them. They're for-profit businesses. They have shareholders. They have to deliver earnings per share. They're going to get the best rates possible from you. And you have no other game in town. You've got to pay it.
Yeah, one of the things I'll jump in as maybe someone who lives in this space on a regular basis on this one as well, which is there's a couple of dynamics behind the scenes, which is the providers are contracting with the networks not only for the self-funded business, but also for the fully funded business and the Medicare Advantage business. And so what happens is the networks may or may not be looking out for the best interests of the self-funded plans, because the payers that own the networks make more money on Medicare Advantage and on fully funded plans. So when a provider says to a network, if you would like me to participate in your network, you're going to have to pay these concentrated, monopolistic, or duopolistic prices. The network says, well, I make a lot of money on Medicare Advantage and I make a lot of money on fully funded. Am I really going to go to bat for my clients in the self-funded market? And some networks will and some networks don't. But if they don't, right, then there's an opportunity for the self-funded plan to look around for more creative solutions. And in our world, in the renologic world, what we do is we use a carve-out combined with a fair market pricing, what some folks might call reference-based pricing. And that allows you to bring down the disparity between what is the network price and what is a fair market price as established by Medicare and others for the service. And it's because there are some perverse incentives for the networks themselves. They don't always look out for the best interest, as well as they may not just have any choice, right? They may not have any opportunity to push back on the dialysis providers. So that's why the kind of in a non-competition market, networks can actually prop up a price as opposed to reduce a price, because there's no volume to be traded, right? When there's only a couple of players in the market. Tom, anything that you would add to that?
Yeah, no, I think you've hit the nails on the head. I mean, it's an interesting situation in which you have our stated goal is free market creates and guarantees better competition, more creative treatment models, more entrants into the market. And we've simply allowed this and many other spaces to degenerate from a free market competition into something that harms everybody on the field.
Got it. We had another question here, and Dallin, I see your question. I want to get through a couple more things, but we'll come back to this specifically around coverage here in a second relative to Cobra. So I promise we'll get to that one. Want to talk a little bit again about maybe market outcomes and challenges, and maybe how you talked a little bit about getting a bad deal, Tom. But can you talk about other ways that the market is failing generally, and if there's anything specific for self-funded plans?
Yeah, absolutely. I think I've already touched on how in each of the boxes that we should be ticking positively, patients, workers, nephrologists, and taxpayers were losing out because of this market concentration. But specifically on the topic of this call, I mean, it's our market failure is failing plans, especially self-funded plans. This market offers very limited access options for plans, and more specifically, very limited access for their employees. And having fewer places to choose from means that plans, in particular self-funded plans, are paying more for that limited access. Dialysis costs have risen at double-digit rates annually for the last decade and more. And at the same time, as we've said, paradoxically, the clinical outcomes have worsened.
Ryan, as an economist, and as you look forward, kind of what do you see happening in the market?
Yeah, so one big trend that we've touched on but haven't talked about in much detail yet is the relationship with nephrologists in this whole system. And usually think of your physician as the checks and balances on the system. They're going to advocate for you the best care possible, Hippocratic oath. But a new trend we've seen in the industry, dialysis chains are now partnering with physicians, either through an explicit ownership stake, the physician buys in part of the chain, or often they have a medical director position that in some ways the compensation is tied to how many patients they deliver to the clinic. Again, not explicitly because by law that's forbidden, but we've seen some evidence in the data that the more they're paid by the facility, the more patients they're sending to that facility. So for us, it's a correlation that's suggestive of that type of relationship. And what that means now for patients, for payers, there's no one stopping the big dialysis chains from doing what's best for their profits. It might not be best for the patient. We're removing that layer now of oversight that we used to have. Again, it's becoming more and more rigged against the patients and the self-funded plans to get high quality care at a reasonable cost like you get for Medicare.
And I also, just to jump in, I also chronicle in my book several cases of senior nephrologists who have attempted to tailor treatments for individual patients who needed more specific care, longer treatments or another monthly treatment, and found a lot of pushback, a lot of resistance from managers, financial managers who weren't medical experts at all, ultimately, helping to dictating the kind of medicine that these doctors are practicing.
Yeah, because Tom, that's the fast food approach again. When you go to Ruth's Chris, you can say, I want medium rare or I want well done. They'll tailor the steak to your needs, what you want. At McDonald's, you can't do that. That's what's happening in dialysis, right? They give nephrologists an operating manual, right? By law, the physician can override that, but it's just too costly. The system is set up in a way that it's going to take too much effort to deviate from their protocols. So we see that time and time again.
And if you look at the recent legal settlements, which I should say have been settled, so the companies have not been found guilty of in many cases, but the settlements, are in the $400–500 million range. You see how the evidence is very suggestive of these corporate treatment plans, these treatment models being really tuned to profit rather than patient outcomes.
So let's turn, I think, a little bit specifically, we've touched on it along the way a little bit, to the implications for self-funded plans. And, I think a little bit here, on the stop loss side. So for smaller plans, generally we're going to see stop loss kick in. And kidney disease is, particularly end-stage renal, is almost always a top 10 stop loss category for folks. But talk a little bit maybe about home dialysis and transplants as it relates maybe to kind of utilization and maybe how the incentives are aligned. And I know, Tom, you've talked to folks, and Ryan, you've done some research around at least transplants, if not home dialysis uptake. But that's one way for self-funded plans to kind of think about alternatives to the high cost of in-center hemodialysis. But maybe we can start with you, Tom, to kind of talk about that reality, and then Ryan, some of the research you've done relative to the incentives around transplants.
Yeah, I before being a journalist, I worked in an investment bank for a while, and if you have 7,600 outlets, brick and mortar outlets, and yours, as Ryan McDevitt said, is a volume business where every new patient goes straight to the bottom line, you're going to be cranking people through those brick and mortar facilities, and home dialysis, by definition, is a more tailored. You don't have the facility with the same staff. You have to go and at least oversee to some extent the care. It's a vastly better outcome for patients. It allows them to regain control of their lives in many cases. But I've seen time and time again evidence that despite a lot of noise about increasing market penetration of home dialysis in their annual reports, ultimately, these businesses are built on their brick and mortar facilities, and there's still some residual disincentives in the law that make home dialysis in America more difficult than it is in other places. I mean, you don't have assisted home dialysis paid for by Medicare. That's a problem, at least for now. So that's kind of where we are with home dialysis. The transplant world, there are some disincentives there as well, among which after 3 years, Medicare stops paying for your anti-rejection medications, which is really kind of a slap in the face. I mean, it's almost ludicrous to say, okay, we'll give you a transplant, but after 3 years, we'll stop paying for the medication that you require in order to hold on to that transplant organ. So I think the playing field is skewed towards brick and mortar right now.
Yeah, I mean, Tom, like you said, that's cruel from a human rights perspective, but it's foolish from a fiscal perspective, because every transplant we give saves Medicare $100,000 per year in dialysis costs. So it's counterproductive from a fiscal standpoint. I would say it's stuff we see on the innovation. You nailed it. The infrastructure's in place. Corporation, they want economies of scale. Once they have that infrastructure set, they're going to try to spend as much money from that as possible. Deviating to go to home hemodialysis, that's going to require a lot of changes to their system. It's just not in their best interest to do it. And then the other impediment I see it is it actually requires a lot more of the patient. And some patients, unfortunately, don't have the right living conditions to support home hemodialysis. It's still a cumbersome process. It's not as streamlined as it should be or it could be. And so that's just where we're at currently. I think what we're waiting for is the iPhone of home hemo. We haven't had that breakthrough, easy to use device that everyone can just bring home. And once we get that, there'll be a stopgap. I mean, what we're striving for as a system is just remove kidney disease once and for all, maybe through artificial organs, maybe it's through drug interventions. But until we get to that point, probably in our lifetimes, but it's going to be a while. What we need is a great, easy to use home-based system, because it improves your quality of life dramatically, and it allows you to keep your job. That's one of the biggest hits we see, and one of the most demoralizing aspects of kidney failure is that you can no longer have steady employment, because no one wants a worker who's going to be going 3 times a week for 3 to 4 hours at a time during the workday to go get their medical treatments. It's just not feasible from an employer standpoint. And if you're thinking your self-funded plan, just your own selfish motives to get more productivity out of your workers, that would be an easy place to start, is to advocate for more home hemodialysis. So doing it at night, it's better for the patients. It's better for you as an employer. That's a win-win as far as I see it.
And that's the
I
original
think,
vision of Congress. I mean, when this became Medicare for all for dialysis for this specific ailment, Congress was sold this on the basis of returning people to the workforce, becoming taxpayers once more, able to really, afford a good quality of life. And that has been that original vision of Congress, frankly, has just been left far behind.
It just restores some basic dignity to these patients.
well, I think that's a nice transition for us to kind of get into some of the specifics about what's a self-funded plan to do. And maybe before I throw it over to you guys, I think just to a point around transplants, Ryan, that you made me think about, which is, the economics for an employer group are the same as they are for Medicare, right? So if an employer is spending $250,000 a year on dialysis, a transplant over a very short period of time is going to be a much better financial investment. And to your point, that worker is much more likely to be able to return to work with the transplant. And by and large, although not uniformly, by and large, those that are on commercial insurance or self-funded plans are going to be on a relative basis younger and healthier and better transplant prospects than those that experience end-stage renal disease later in life. And so I think that whether it's home hemodialysis or transplants, it is an opportunity to educate and support patients on alternative clinical options that really make a big difference from a financial and a quality of life standpoint.
Yeah, and what's left unsaid there, Kevin, is the conflict of interest from the big chains. They lose a customer if they get a transplant, so they're not going to advocate for those like the employer or the patient would probably desire. So just keep in mind, someone's financial interest might not be aligned with your own when you walk into the clinic.
In fact, there's some very good peer-reviewed research that shows that when a clinic is bought out by a major chain, the number of people inscribed on the transplant list drops off. So,
Yeah, I'm familiar with that paper.
So let me, I wonder who wrote that paper. Wanted to circle back to a question from one of our attendees. And I'll read it for the benefit of all the other attendees. So it's our plan recently experienced 2 members who could not work due to dialysis needs, as we just talked about. Both members had Medicare, but the dialysis centers enrolled them in COBRA and paid premiums for them. How can a health plan address this abusive profiteering strategy? And so I'll ask Tom if you want to kind of jump in first. I know neither of you are regulatory lawyers, but if you guys want to try to answer that question, and I'll add my own perspectives as well.
Yeah, just as an investigative journalist and not, as you say, as a legal authority, there's an enormous disparity because of the difference in pure value between privately insured patients and publicly insured patients. There's an enormous disparity in the way in which patients are treated, frankly. And there's a huge benefit, let's say financial benefit, to dialysis providers to have privately insured patients. And so, you have COBRA, you have various maneuvers that dialysis clinics routinely offer to patients. Another one is the American Kidney Foundation. They strongly disagree with my contentions in my book, but I frankly stand by what I and various legal authorities have said in the past, that the business of paying to allow people to stay on private insurance can create loopholes in their care that down the road are very dangerous. And ultimately, the people who are funding the American Kidney Foundation, in many cases, are the very people who are benefiting on the far end because they have private patients rather than Medicare patients. So this doesn't quite answer the question about what to do about COBRA, but it certainly, there is a major concern about how there's a 2-class system, if you will, with public and private patients. And there's a big question about the legitimacy of keeping people, let's say artificially, for lack of a better word, on private insurance.
Yeah. And so what I can say from the Renologic perspective is the same solution set, right? When it comes down to the benefit design for the plan, right? And say, how is the plan going to reimburse providers for dialysis services? That's the same solution, whether they're originally directly on the plan or they're playing, accessing those plan benefits through COBRA. And so whether you adopt Renologic or a similar solution that allows you to contain that cost on the front end, that will flow over to anybody who's covered on COBRA. The challenge is that today, right, everyone is eligible for COBRA. And, that's a good thing in kind of the coverage and as citizens, if you will. It's a challenge in this instance when, as Tom suggested, folks are artificially propped up on COBRA from outside organizations who have their own interests, financial interests, in doing so. And so there have been some investigations into that practice for these charities that are providing premium for COBRA. I think we'll see more of that on a regulatory basis. But as a plan, the best thing that you can do is on the front end in the plan design process, adopt some solution set that is designed to control the cost. And whether that's Renologic or something else, that's the way it would apply through on COBRA. Ryan, maybe, we've got a few things here, but, what if you're running a self-funded plan, and COBRA is certainly a piece of it, but what else would you be doing trying to find solution sets to this problem?
Yeah, first recommendation I make when people reach out to me about this is, get inside your data and know what's going on with your enrollees. It sounds like a basic step, but a lot don't even do that basic measure of figuring out how many of their employees are at risk of developing kidney failure, maybe progressing to dialysis. So knowing what's at stake, and then knowing what your options are. How much are you paying for this? It might come as a shock. You might not even have a good sense of how much excess you're paying for dialysis patients. Another recommendation is intervene early when you do detect someone who might be at risk of developing kidney failure. Every dollar you invest in prevention today will save you $10 on the road, if not a lot more than that. And there have been some great preventative interventions now. We had the SGLT2 inhibitors, the GLP-1 agonists, so breakthrough drugs. Those are going to be cost effective. The price tags might look large, but they're much cheaper than dialysis in the long run. So think about that. The other is, be a little bit more creative about how you think about your plans, tailor them. Working with Renologic a little bit, I've seen some of the innovative things they're doing. It's not a sales pitch, but just to demonstrate that there are options out there beyond just the cookie cutter approach that might be first thing that comes to mind. And then, finally, work with experts. You talk to an economist. This is a messy business. I've been spending 10 years, a PhD in economics. It still baffles me every day when I learn some new nuance of this industry. And so, be a little humble that it's going to be really hard to figure this all out. So talk with people who have spent a lot of time researching this messy sector.
Well, I feel a little better now, Ryan. Thank you.
Yeah, I think one of the things that one of the attendees asked was about kind of early detection, which you mentioned, Ryan. And I would tell you that there are a host of analytical solutions. Obviously, Renologic has one, but there are solutions that will either be claim-based or EHR, clinical database, or testing-based that will give you some sense of where a patient, a member is at relative to their risk for end-stage renal disease. And so for our clients, we provide kind of a regular monthly or quarterly update on the patient population on a risk stratified basis, just specifically to kidney disease, with a predictive attempt to say, oh, it looks like Tom or Ryan might be headed towards kidney disease or end-stage renal disease specifically. Can we intervene, and can we enroll, and can we get them a different level of support than those that are maybe much more earlier stage? And we know what the comorbidities are. Ryan, you mentioned the weight loss drugs, the Ozempics of the world and things like that. But getting folks to lead a healthier life early in the process can certainly forestall this. I think we made it clear up front, but the number one driver of end-stage renal disease is diabetes, and type 2 diabetes is the largest percentage of that, which in turn is driven by obesity and kind of cardiac disease. And so all of these comorbidities together, the sooner we can get folks to involved in kind of clinical solutions, kind of removes the challenge down the stream as well. One of the folks asked in the chat about trying to implement a carve-out solution and getting pushback from TPA, and in this case, they named Meritane specifically. And I would tell you, this is the world that we Renalogic live in. And the challenge is, and I'm glad you mentioned Meritane specifically, because Meritane is obviously related to one of the large networks. And that network has got that cross incentive relative to pushing back on providers. And so I would tell you that from our perspective, we do this hundreds of times a year. There is a spectrum of networks, from those that are honestly trying to work and well serve the ASO market, to those that are say, hey, I've got pricing power of my own in the network. And this is where knowing your rights is so important. For anyone that's interested, we Renalogic have a document about what you're allowed to do from a carve-out perspective. I would tell you the ultimate answer to that, right, is switching networks, or bringing litigation against the network. That's a very extreme and often unnecessary, but a direct set of conversations with the network, with a commitment and an understanding, armed by data, really suggests that most of the time results in ability where that network or the TPA is willing to work with you. It's usually not the TPA, an independent TPA that's unrelated to the network. It doesn't have the same incentives. For those that are related, particularly for those that are related to the BUCAs, they have a little bit of cross incentives going back to what I mentioned with Medicare and fully funded relationships as well. And so it is a question of whose data is it, who has rights, and at the end of the day, maybe we can talk a little bit about this, is the increased pressure on fiduciary responsibility. This is one of those areas where paying 7 times Medicare, is that really a good use of member funds? Can you as a sponsor stand in front of whatever regulatory agency is going to come and ask you, are you doing your job as a fiduciary? Is that okay? And how hard do you then have to push back on other stakeholders who may have cross incentives? I think it's a very good question. Again, this is something we do all the time. I would encourage everybody to have the data, work with someone that really knows this, and understand your rights in the carve-out space. And most of the time, it stops well short of any sort of switching or litigation. But that's the marketplace. At the end of the day, you've got to look out for the best interest of your members and your plan. As we kind of approach the end here, any other thoughts on that fiduciaries piece? This is kind of happening in front of our eyes, with some kind of litigation that's pumping up. Ryan or Tom, I don't know if you've seen this stuff specifically. It's certainly not yet related to dialysis, but any thoughts on how that might develop or shape the market here?
Well, I'll just say, I mean, a lot of these things I've learned from you and your colleagues at Renalogic, but I mean, the industry is moving really, really fast, and expectations and requirements within the industry are also changing really fast. And as you mentioned, there's plans have a fiduciary responsibility to be good stewards of their assets, and part of which is not overpaying. So plans will be more and more expected as transparency in healthcare prices rises, we'll be more and more expected to, to do more in this space in the past. So again, as both Kevin and Ryan have said, know your data. And to have reliable access to data, plans also have to know their rights. I mean, what they're entitled to, and they have a right to the data, and they have rights concerning which parties they can share that data with. But again, there are stakeholders with different incentives that may try to block plans from having or sharing that data. But you really do have an obligation to access that and to understand it. So it's really hard to keep up, as I know, and I can imagine people out there are experiencing, hard to keep up with this fast changing landscape and regulatory issues that arise pretty regularly. So again, as Ryan has said, keep in touch with experts, keep in touch with trade associations that protect employer and healthcare purchasers' rights in an effective way. I'm thinking of the American Benefit Council and ERIC and SIA and CIAB and others. These groups, are all have Washington-based teams that are looking out for plan interests, including in the dialysis space.
Great. I know we're coming up on time.
Kevin, from just the macro perspective, it's not sustainable to have these healthcare costs growing the way they have been for the past 50 years. We're already spending 1/5 of our economy on healthcare. Something's got to give. And there's going to be a lot more scrutiny. So, looking at the fiduciary duty of these stakeholders, that's going to be one piece of it. But more changes are coming because they have to change, or we're going to be bankrupt as a whole economy. Something's got to give.
Yeah.
Are there any other questions from the audience? Please go ahead and write them in. One of the things that we purposely didn't do is try to kind of turn this into a Renologic commercial. But just in the close here, what I'll do, while maybe folks ask another question again, is there was one question about what do we do, Renologic. So again, what we bring is specifically to dialysis is first we bring a set of clinical early detection and clinical education and support services to those that have chronic kidney disease and as they move towards ESRD. So educating folks on what their options are, both for home healthcare or for home dialysis, for transplants, for Medicare coverage, making sure that they understand this very complex world. With very, very few exceptions, there is not a lot of expertise inside a HR department for the nuances of dialysis and end-stage renal disease, whether that's regulatory or otherwise. And so we try to bring that on an outsourced basis to the plans. And then the other, on the cost containment side for dialysis specifically, we work with those plans to change the way that the benefits are designed to bring a fair market price approach. So we carve that benefit out and we try to bring a fair market pricing methodology to bear to help those plans establish what is a fair market price. And that fair market price can vary by market, by definition, but generally is much more in line with the other disease states. As you said, Ryan, our US healthcare system does provide for cross-subsidization by commercial plans versus government plans. Commercial plans are always going to pay more, but not 7 to 10 times more. And so our solutions are designed to kind of bring things in line and have been doing that in combination with the clinical and the education services for a couple of decades. And we'll also facilitate direct contracting in those markets where that makes sense for those employers. And we'll do single patient agreements as well. So all of that is part of what we bring. And whether somebody works with us or someone else, I would argue that one of the challenges is that most plans and or advisors and or TPAs, they just don't live in this world all the time. And so there's a lack of expertise around what those options and obligations are. And so that's really some of the knowledge gap that we're trying to close. For those that are interested, obviously, we're happy to do more. So someone asked, is there an intimation that there is spread pricing with BUCAs? I would I would defer until somebody brings the data. So I think that I am very comfortable saying that BUCA networks have cross incentives. I am unprepared to stand hand on heart without the data and suggest that there is spread pricing. I certainly would not be surprised, but I think it is fair to say that there is cross incentives for the network when the provider is pressuring them on two other business lines, Medicare Advantage and the fully funded, versus the self-funded side of the house. And we know where most traditionally payers make most of their money is that not equal amongst those lines of business. So I want to be very careful. As Tom pointed out, the dialysis providers are more than litigious in their approach to life. But I think that there is some cross incentives to be sure. Yes, someone else asked, is this being recorded and get a link to share with other consultants? The answer to that is yes. We'd be happy to do that, as well as kind of share the slides. And I think maybe there was one. Nope, I think that's it. So with that, I want to try and make sure that we end on time and give folks the opportunity to get to their next appointment. Feel free to reach out to us through the registration links if you have additional questions for either of our panelists today. I want to thank Professor Ryan McDevitt from Duke and Dr. Tom Mueller, independent journalist, for sharing their experience and expertise with us today. And happy to help with other questions that may be more specific than what we were able to get to today. But thank you all very much and have a wonderful day.
Thanks very much, Kevin.
Thanks, everyone.
Take care.